So, start off the scientific part of the morning session. It's my privilege and pleasure to introduce Dr. Drew Ridge, president of the Society. Currently, he's the chief of head and neck surgery at Fox Chase Cancer Center, professor and vice chair in the Department of Surgery, and is the Louis Della Penna Family Chair in Head and Neck Oncology. He initially got his MD PhD at Stanford, did a residency in surgery at the University of Colorado with a fellowship at Memorial Sloan Kettering. He holds honors including being the past president of the American Head and Neck Society. Personally, I actually met Dr. Ridge as a medical student at Temple, had the privilege of training and learning from him during my residency at Fox Chase Cancer Center, and it's truly my privilege to introduce him for his presidential address at the centennial meeting of the American Radium Society. Dr. Ridge.
Thank you for coming. I'd like to talk about some things we know. I have nothing to disclose. The humpback whale is my spirit animal. During the first Gulf War, the Society of Head and Neck Surgeons and the EORTC met in Maui because we weren't thought it safe to go to Paris. From the beach at Kaanapali, I saw the most remarkable whale show put on by a single animal for some 15 minutes. I mentioned this in passing to someone who set me up for a job in head and neck at Fox Chase. In the absence of the whale, we may never have met. I'm a head and neck oncologist, and when we care for patients with head and neck cancer, it requires a multidisciplinary team. This is really a sport for people with a lot of confidence and a lot of caring. The team is large, and it's a good reason why it's difficult for even secondary level institutions as opposed to tertiary care to deliver high quality treatment and support to patients with head and neck cancer. In general, when we treat head and neck cancer, we're talking about curative therapy with surgery or radiation, postoperative adjuvant therapy with risk-based radiation or chemoradiation, non-surgical management with chemoradiation, of which organ preservation is a special case, and systemic therapy, which is largely, though not entirely, administered with palliative intent. Tumors are located in areas that are essential to speech, swallowing, taste, and appearance, and critical structures such as the brain, eyes, great vessels, and lungs are nearby. Even successful treatment may leave patients with significant functional and cosmetic impairment, and late treatment complications may prove fatal. Now, you can't get something for nothing. There are true disadvantages to surgery. It causes acute injury and dysfunction. Rational individuals don't want an operation. If someone comes to me and says, I want an operation, Dr. Ridge, I tilt my head and look at him carefully. Most procedures require general anesthesia, and some patients are poor candidates for resection because they're too ill to undergo the operation itself with respect to the anesthesia, or else they're unable to participate in rehabilitation. And with an operation for a head and neck tumor, if someone can't participate in rehab, you can drop them into a hole from which they cannot climb out. And treatment may engender chronic dysfunction with respect to speech and swallowing. But radiation treatment has disadvantages as well. It typically lasts for weeks with acute side effects that are substantial with respect to mucosal injury and dysgeusia. And the late side effects never remit, and indeed they worsen with time. Obviously, this audience is more than familiar with xerostomia, resulting compromise of teeth, the obliterative endarteritis with fibrosis and radionecrosis that bedevil us when we treat patients with a non-surgical approach to a head and neck cancer. Now, organ preservation represents a special case of radiation treatment. It began in an effort to avoid major organ loss, and in the head and neck we would recognize this as a total laryngectomy or total glossectomy. The morbidity of such resections is substantial, and they engender immediate, complete, and permanent decline in quality of life. And the dominant considerations for organ preservation are the quality of speech and swallowing and the side effects of treatment. But somehow, between the 1980s and 2000, organ preservation actually underwent a subtle but important change. And it turned into an effort to avoid operations. And I think it's really, really important to remember that. Many of the patients treated with so-called organ preservation actually had, for instance, tonsil cancers. It's hard for you to tell me that the tonsil's doing anything that needs to be preserved, and I assure you that whatever it's doing, it's going to stop doing after you radiate it with curative intent. So what really happened is that organ preservation became non-surgical management, and this wasn't really fully recognized by the community. Now, the scope of the problem in 2016 would show us that there are almost 70,000 patients a year in the United States with cancers arising about the head and neck, and they engender tremendous morbidity, and indeed all too many patients succumb to the disease. We recognize that there are essentially two types of head and neck cancer. There is the so-called HPV negative that arise at all sites, and they're chiefly keratinizing. They afflict older individuals, chiefly men, of lower socioeconomic status. And the risk factors are alcohol and tobacco abuse. Poor dental hygiene is an associated risk. Fortunately, the incidence of this disease is declining, and they're characterized by worse survival than tumors that are associated with HPV infection, which largely arise at the tonsil and tongue base and are chiefly basaloid rather than keratinizing. They attack a younger patient population, though the male to female ratio is still 3 to 1, probably not due to habits, but rather to the quality of the immune system in women. Patients typically are from a higher socioeconomic status, and the risk factors are the variety and number of sexual partners and acts, though marijuana use may represent an associated cofactor. The incidence is rising dramatically, and the survival is better. Now, this is a scientifically sophisticated audience, and we'll recognize that there aren't just two types of head and neck cancer. There are many types of head and neck cancer. When I wear my lab coat, there are a lot. When I wear my white coat, there are two. And basically, we care for patients who have either an HPV negative or an HPV-associated tumor. As I mentioned, the dose-response relationships for tobacco, alcohol, tooth loss, oral sex partners, and marijuana use are seen here. And on the top lines, you see a lack of association with tobacco or alcohol use. On the bottom line, you see dramatic impact of smoking, use of alcohol, and indeed associated tooth loss with no association in marijuana use. The incidence of oropharyngeal cancer in the United States is rising. Now, this is essentially a semi-log plot, and so comparatively small apparent changes reflect factors of 3. And the tumors that are associated with substance abuse are declining in incidence, whereas those shown in blue associated with HPV infection are rising dramatically. And there's no reason to believe that this trend will cease in the next decade or so. We can, of course, hope that the vaccines will have an impact through herd immunity and diminishing exposure to the oncogenic subtypes. But for now, this is an incipient epidemic. The ECOG 2399 was the first prospective trial to evaluate treatment of patients taking into account their HPV association of their tumors. It was published in the JNCI and shows that patients who had HPV-associated tumors treated with this light induction and chemoradiation light regimen did far better than patients whose tumors were not HPV-associated. The recognition that these were oropharynx cancers was confirmed. And that study, prospective, carefully designed, and landmark, is very seldom referenced by comparison to this important secondary analysis that came out in the New England Journal, authored by Ken Ang, and Maura Gillison is the senior author. This is a secondary analysis, but it was in the New England Journal. Even for oncologists, it's not true that everyone reads the JNCI. And so the secondary analysis is far more frequently referenced in the report of Fakhri and coworkers, but it also shows a difference in survivorship between the patients with HPV-associated tumors, in this case referenced by either HPV or the robust surrogate biomarker of P16. And the risk of death could be broken down to show three different classes of patients: those with quite a low chance of succumbing to the disease, and patients who are at high risk, as well as an intermediate group based on anatomic and smoking as factors. Now, this is really an important and interesting observation because it illustrates that the staging system is effectively broken for patients with HPV-positive head and neck cancers. If you look at this review of some 1,900 patients recently published by O'Sullivan and coworkers, on the right, you can see that the staging system for HPV-negative oropharynx cancer really works quite well with a good breakout between stages 1, 2, 3, and 4. But on the left, if you look at patients with HPV-associated tumors, you see that there's essentially no discrimination whatsoever between stages 1, 2, and 3, and 4, and 4A indeed, and only stage 4B, those with N3 nodes, seem to have a worse prognosis. Now, we achieved these excellent results for patients with stage 1, 2, 3, and 4A head and neck cancers with HPV association as a result of increasing, or in association perhaps, with increasing intensity of therapy. This slide is from a seminal report of Andy Trotti in Lancet Oncology that reflects on the escalating morbidity of chemoradiation administered through the 1990s. And it really confirmed something that had been bothering a lot of participants in the field a lot. And what was going on was we were increasing the intensity of therapy, and the side effects for those of us delivering the care seemed to be rising dramatically, and yet the reports really didn't reflect that. If you look at the bars in red, those are reports based on single worst grade of toxicity in the regimens reported. In white is a summation of toxicities 3, 4, and 5. And this reporting approach, which misled us about the toxicity of therapy, was a direct result of toxicity reporting in drug studies. And the reason for that is because if you give somebody a drug and they have a severe grade of toxicity, you say, well, I won't do that again. And all you have to report is the worst grade, okay? You give the drug, you get a dysrhythmia, you get Steven Johnson, you say, okay, that's it. We're just going to count the worst grades. But that's not what happens when we're treating people with radiation. There is no single toxicity. In the main, we see multiple toxicities. Now, when patients are treated with radiation alone, you look at the left side of this graph, at this graph, post-op radiation, conventional radiation, radiation alone, you see very little disparity between the worst grade toxicity and the sum toxicities of grades 3, 4, and 5. But when we begin interpolating chemotherapy into the regimens and altering the fractionation, what you see is a dramatic increase in the aggregate toxicity of therapy, which is not really reflected in the worst grade, which is what was typically reported for the regimens. Believe me, I've got a lot of patients in these bars. I was taking care of them as the surgeon, you know. What I'd tell the patient is see the radiation oncologist. You'll have on-treatment visits weekly. I'll see you a month after radiation ends, and if the radiation doctor wants you to see me sooner, he'll tell both of us. And boy, I was seeing a lot of patients sooner. And so this was a really seminal observation of Andy Trotti's, that the morbidity of the radiation treatment was rising dramatically as we undertook these trials. And patients were doing better and better. So we said, whoa, we're treating patients more intensely, but look, they're doing better and better. The control arms were doing better than expected. We said, wow, this is great, our supportive care is improving. But it turns out that wasn't what was happening. What was happening since the 90-03 through, say, the 05-22 was that there was a dramatic increase in the percentage of patients with HPV-initiated tumors in the trial populations. What you see in green is how long the trials took to run. And over the course of these years, from 1990 to 2005, the incidence of patients with HPV-initiated tumors went from 40% to 75% in the 05-22. And meanwhile, the median pack years of smoking dropped from the 50s to 12, even among the smokers, and from patients with HPV-initiated tumors, from 30% to 5%. So what was happening is, unbeknownst, the trials were being populated by individuals with very treatment-responsive tumors. And we were misled into thinking that what was working well was the increasingly intense treatment that was really pushing the bounds of early and late toxicity. Not shown on the slide before, this is a study reported by Jim Bonner in the in Lancet Oncology for the long-term analysis, comparing treatment with cetuximab to radiation alone, which also showed efficacy for this biologically targeted agent. And the estimated toxicity burden from treating patients with cetuximab and accelerated radiation was thought to be quite similar to concomitant boost RT in the 90-03 study, which was really an accelerated fractionation regimen. And so we thought we could estimate the acute toxicity burden from cetuximab with concurrent cetuximab with radiation and compare that to the frontline standard of care of giving concurrent cetuximab with accelerated radiation. And this was done in the RTOG 1016 trial of patients with tumors initiated by HPV. And what we wanted to do was to see if we could assure that there was no decline in survivorship with a dramatic reduction we anticipated in acute toxicity burden and a better similar long-term swallowing function for patients who survived. And by long-term, we would define this as more than 10 years. Now, more than 10 years is decidedly long-term, but it shouldn't be interpreted as a proxy for lifetime in a young, healthy patient population. So these are some of the things that we know. But there are some things we don't. And I'd like to touch on a few of them in the remainder of this address. We really don't know the significance of P16 positivity or HPV status at non-oropharynx sites. Nowadays, we see path reports, patients come in with a tongue cancer, the pathologists have seized the opportunity to charge. You receive an immunostain report that says this tumor stains strongly for P16 or this tumor does not. We're getting information. Do we know what to do with it? As I said, we really don't know how to stage HPV-associated oropharynx cancer. And I don't think we really know how to ameliorate the toxicity of the regimens, which are admittedly highly toxic, without compromising our cure rate. If you look at this report of analysis of pooled results and pooled patients from RTOG studies published by Christine Chung, what you see is that patients who do not have oropharynx cancers seem to have a somewhat better prognosis if their tumors are HPV or P16 positive than patients whose tumors are not. And you know, we recognize that, as I said earlier, there may be two types of head and neck cancers, those that are HPV positive and those that are HPV negative, with different profiles from the standpoint of their genetic mutational background. The incidence of non-oropharynx P16 high and HPV positive tumors is variable across reports, and it's probably about 20% for P16 and about 5 to 10% for HPV. Now, in the oropharynx, P16 is a very, very robust marker for an HPV-associated infection, but its significance in oral cavity and larynx cancers is decidedly uncertain. But I think that there's something to be seen here, and we need to figure it out. If you look at this slide, what you see is the progression-free survival, or the overall survival, in yellow for patients whose tumors are not caused by HPV at oropharynx and non-oropharynx sites, and they effectively overlap. At the top in blue, you see the really quite fine, though not great, prognosis for patients with tumors of the oropharynx that are initiated by HPV, and intermediate patients whose non-oropharyngeal tumors are caused by HPV, or pardon me, P16 associated. And I think that while we acknowledge it's far too soon to modify treatment based on P16 status alone outside of a protocol setting for the oropharynx, and I really don't know how to modify therapy for patients who have P16 high tumors in the oral cavity, many of whom are treated by operations, and so we're really looking for an entirely different background of toxicity and perhaps adjuvant therapy. Now, when I say that the patients do very well, this is really an important observation about the staging system and how the staging system isn't working. Dr. Shah mentioned this seminal work by Groom, published in 2002, surrounding desirable features of stage groupings. And it's something which is really important to remember, and I think worth communicating to our trainees and residents. In a stage grouping, the TNM-based subgroups should have similar survival rates in terms of hazard consistency. So everybody in a particular stage should do about the same in terms of their force of mortality. They should group pretty closely. Regardless of the TNM, if they are in a stage, you want them to have a consistent hazard. You'd also like the survival rates to differ across the groups, and this is the problem that we have with HPV-initiated oropharynx cancer. Stage 1 should do better than stage 2, which should do better than stage 3. You want these things to splay out so that you can predict cure based on the patient's initial stage. And one of the things that we use a staging system for is to counsel patients surrounding their prospects and to bear these in mind as we design treatment. And ideally, the distribution of patients across groups should be balanced. And this is really to confer statistical power. But you know, patients walk in and those are your demographics, those are the breaks. You really can't control how many patients have distant metastatic disease, for instance. And so you can't say, well, we're going to have as many stage 4s as we have stage 2s. We get what we get. Now you can imagine staging with different stage definitions by site. And for instance, in the AJCC 7th edition, nasopharynx has unique node staging among the head and neck sites. So head and neck oncologists can memorize the node staging for tongue, oral cavity, larynx, oropharynx, and those are all the same, and nasopharynx is different. So in this situation, we change the site, and as a result, we change the stage classifications. And that would be one way to deal with a breakdown in the staging from oropharynx cancer. Another approach would be to have different stage groupings within a site. Thyroid cancer is an example of this. The T, N, and M stages for thyroid cancer are all defined similarly, but the stage groups differ. So that patients with papillary thyroid cancer have a stage grouping that changes with age, and the force of mortality is low, so in young people there's only stage 1 and stage 2. And if you look within the different disease sites for thyroid cancer and find papillary, medullary, and anaplastic cancers, these all have different stage groupings within the site. A different approach would be to define different diseases within a site. And skin is a good example of this. That is, cutaneous squamous cell carcinomas and other cutaneous carcinomas such as basal cell are staged one way. Merkel cell carcinoma of the skin is staged another way, as is melanoma. Now, these three different methods are all found within the AJCC 7th edition. And while I consider the particular stage groupings and definitions to be embargoed, I don't think I'm giving away too much to say that the AJCC UICC 8th edition staging is going to adopt an approach to finding different diseases within a site, so that medullary thyroid cancer will not be having the same stage grouping as papillary. It'll be found in a different chapter. And indeed, HPV-initiated oropharynx cancer will be considered to represent a different disease than an oropharynx cancer caused by substance abuse or a non-HPV initiation. The stage groupings will be different, and you'll find them in different chapters. Now, I alluded to the difference in survivorship and the limitations of the stage grouping earlier, and showed data from O'Sullivan recently published in Lancet Oncology. And I direct attention to the right-hand side, where stages 1, 2, and 3 are proposed in this large series of an international consortium. And it does really nicely illustrate the idea that stage 1, 2, and 3 have different prognosis. Stage 4 would be distant disease, and those patients were not analyzed in this report. And one proposed stage grouping, which I think has a lot of currency and ease of use, which is a worthwhile, though not essential feature of a staging system, would be something like this, where patients with small primary tumors and small nodes are in stage 1. Stage 2 goes all the way up to a T3 tumor, fairly large in the oropharynx, greater than 4 centimeters, and includes multiple nodes and contralateral nodes or a single large node. And stage 3 would include patients with massive primaries or a node 6 centimeters or more. This is a stage grouping that might be employed for oropharynx cancer. You can see how it would work very readily for tumors caused by HPV. And this is a staging system which is essentially clinical. Clinical staging is really important when we manage patients without an operation, right? Pathologic staging is useful if you're going to take the tumor out and you're going to look at it under the microscope. The majority of patients with oropharynx cancer in America today are managed without an operation. And so what we really need is a robust clinical staging approach. But this raises an interesting question, because the data that I showed on the previous slide largely result from non-surgical management, and it reflects a clinical staging system. But if you look at patients who are managed with operations, you see something which is perhaps paradoxical. The chance that a patient experiences a recurrence does not seem to be related so much to the size and distribution of the nodes as to their node number. And this is a result of a report of a large surgical series of some 200 patients, where you see that the risk of recurrence rises dramatically as the number of nodes increases, and it's up to 25% when patients have 5 nodes or more. And when you look at the disease-specific survivorship in this surgically managed series, what you see is that the survivorship from patients with 4 or fewer nodes in the top of the graph is really quite good by comparison to patients who have 5 or more involved nodes. And you can also see, and this is an interesting and provocative observation, that in those patients with 4 or fewer nodes involved, there is a decidedly limited benefit from the administration of adjuvant radiation or adjuvant chemoradiation, and these patients do quite well managed with an operation alone, regardless of whether they have multiple nodes involved or the actual end status of the nodes. Note that when you have 5 or more nodes involved, there's a decline in survivorship in this situation, and in red, didn't happen very often, but when it happened, it was bad. If you don't get adjuvant therapy in that situation, your prognosis is decidedly harmed. So if someone has an operation for a P16 high or a pharynx cancer, they wind up with 6 nodes, I'd recommend adjuvant therapy and do my best to make sure the patient receives it. So this has created an apparent paradox in the sense that patients who are managed surgically and will provide you with pathologic information have a different set of prognostic parameters than patients who are staged clinically. And this is an unresolved paradox. And the fact that patients with fewer than 4 nodes or 4 or fewer nodes involved do so well highlights the need to reduce the morbidity of therapy in this patient population with de-intensification. Remember, our current treatment methods are really highly morbid with significant short-term and durable long-term toxicity of therapy, which is particularly onerous in a setting where patients are young and with little comorbidity, because we anticipate long-term survival of decades in these patients that we largely cure, and we don't want to have hurt them too much in service of that tumor control. I mentioned the 1016 study, where we might try to replace cisplatin with cetuximab. We could, of course, try to reduce the dose of radiation or chemoradiation. These are really highly treatment-responsive tumors. If they're that responsive to treatment, let's not hurt them too bad. Let's treat them a little less intensively. Another approach might be to use induction chemotherapy and follow it by reduced dose radiation or chemoradiation. We recognize chemoselection is one way to identify patients who have radiation-responsive tumors. And if patients' tumors respond well to induction therapy, then perhaps we can treat them less aggressively with radiation. And another means of de-intensification in the modern era is actually to undertake an operation. I can give you a CR in an afternoon. It's going to take you guys weeks. And so this is really a form of de-intensifying therapy if properly applied, and it affords the chance to use risk-based adjuvant therapy rather than to apply it empirically on the basis of clinical staging. So I showed this slide before about the RTOG 1016 study, where we hope to identify a difference in toxicity without a decline in survivorship between 2 regimens of very different acute toxicity and probably very different durable late effects. Again, trying to reduce the acute toxicity burden for the patient to increase adherence to the regimen, help the patients get through it with similar or better long-term swallowing dysfunction. And the RTOG 1016 study was undertaken with 1,000 patients. It ran very well, and now we're waiting for the results to accrue. Now, One of the things that concerns us about de-intensification is that we do not want a compromise in cure. If we don't want a compromise in cure, that's a problem, because when we cure most of the patients, we don't get very many events. So it's going to be hard to show that one regimen is better than another. And this study is powered for non-inferiority. That is, it should show, if a positive study, that one of these regimens is not much worse than the other. Now, what it means to be not much worse is an interesting question, and I'll touch on it again later. But with 1,000 patients enrolled, and it took on the order of 5 years and 8 years to analysis, this study is powered to consider equivalent on the order of an 8% difference in survivorship. Another approach would be to de-intensify through shortening the course of radiation or a shorter course of chemoradiation. And the NRG-HN002, chaired by Dr. Yam in the audience, is designed to do that in a randomized phase 2, which is running now and accruing well, where patients with P16 high lesions are stratified to unilateral or bilateral planning based upon the primary tumor, and then randomized to an arm of 60 Gray in 6 weeks with concurrent cisplatin versus 60 Gray in 5 weeks with 6 fractions per week as a form of a form of acceleration. This is a study which will involve some 300 patients and is currently accruing. Dr. Yam in the audience, wave. There she is. Another approach to de-intensification was the ECOG 1308 study, which relied upon induction chemotherapy as a form of chemosensitization and chemoselection to identify patients who were thought to have a good prognosis and to treat them less intensively with a concurrent regimen of cetuximab with radiation, comparing 54 Gray after a complete clinical response to 69. The virtues of this are obvious in terms of radiotherapeutic long-term morbidity if we don't experience a decline in survivorship from treating patients less intensively. If you look at the patients with the best outcome in black, these are patients with lesions less than T4, lesions T1 to N2B, with less than 10 pack years of smoking. And from an anatomic standpoint, you might note a striking resemblance, though not complete concordance, with the data presented by O'Sullivan in a proposed stage grouping. And we see that the overall survivorship in the most favorable cohort is quite good. Tragically, the death in that cohort actually reflects mortality while the study subject was engaged in an extreme sport. It's tempting to wonder whether he'd be alive today if he'd had a more morbid treatment. So this guy actually had such a good quality of life that he was able to die doing something he enjoyed very much. So in this treatment paradigm with that induction regimen, which included concurrent cisplatin with cytotoxic chemotherapy, some 70% of the patients achieved a complete response and were able to have a de-intensification of radiation, an important proof of concept. And the best predictor of outcome was the smoking history, which is indeed a fairly robust identifier of patients with an HPV-initiated tumor who will not do as well. Now, surgical de-intensification is something to which I alluded earlier. And what we find is that transoral resection, whether it's accomplished with a laser or a robot, shows comparable survival results to non-surgical approaches. And it's perhaps less morbid than primary chemoradiation, though we don't know that. Now, we can employ resection of HPV-associated cancers without sacrificing survival, we believe, and reduce the postoperative radiation dose and limit the proportion of patients requiring postoperative radiation by evaluating their pathology specimen, and even by current criteria reduce the need for chemoradiation. But remember that the difference between resection and induction chemotherapy as a approach to de-intensification is substantial. The morbidities of the approaches differ remarkably, and the response assessments aren't the same. So when we treat patients with chemotherapy and induction, what we're really looking at is chemosensitivity, and this is a feature of tumor biology. When I do an operation as so-called induction or perhaps definitive therapy, this is really a matter of tumor bulk and margins and perhaps extracapsular spread. Chemosensitivity and resectability really aren't the same. And what that means is that we need to have an open mind and be vigilant when we look at the ECOG 3311 study, which is a study of risk-adjusted treatment intensity, where patients undergo transoral resection of oropharynx cancers that are HPV initiated. And if they have T1 to T2 with N0 to N1 and clear margins, these patients are managed with no additional treatment. Patients who have high risk with involved margins or extensive extranodal spread or more than 5 metastatic nodes or more, receive trimodality therapy in a situation like this. They're going to have an operation and then chemoradiation. And what we should learn from that is these patients who need chemoradiation, or we believe need chemoradiation, probably shouldn't have operations at all. And it's on the surgeon not to dock the robot in this case. These patients should be managed today with a non-surgical approach. And the study question is really what to do with patients who have clear margins, 2 to 4 metastatic lymph nodes, perineural invasion or LVI. And in this treatment-responsive disease, the randomization is to 50 grave versus 60, which is a dramatic reduction in the possible toxicity of therapy. So remember that, and pardon me, an additional study is the ADEPT, which is a study of de-escalation for patients with ECS in their nodes. This is partly randomized and partly registry because it's not an easy study to sell to patients, to be frank. But in this study, patients with HPV-initiated tumors managed with operations are selected or randomized either to receive chemoradiation or radiation alone to test the proposition that extranodal spread is an important prognostic indicator in patients with HPV-initiated tumors. This is really the only way we can anticipate answering this question. And what we're thinking of doing, or what this study tests, is the proposition that post-op radiation alone, which has really quite low toxicity by comparison to post-op radiation with platinum, can be accomplished without a decline in survivorship. And this raises a really important and worthwhile question, which is whether or not patients will tolerate de-escalation. If you looked at a group of patients who were treated with chemoradiation for an oropharynx cancer in Canada, 2:1, they would prefer radiation alone if assured that the survivorship is equal. But 69% of that population would choose chemoradiation over radiation alone if the survival difference were less than 5%. Now, 5% survival difference is pretty small. And the difference in toxicity, short and durable, of chemoradiation versus radiation is substantial. We know that in breast cancer, a 3% survival difference moves patients and moves practice. And I think it's an interesting observation that among patients with a head and neck tumor in this population, 35% would accept no survival decline at all. That is, if you said there's a 1% greater chance of dying of the disease, 35% of the patients already treated would want more intensive therapy. And in fact, 10% would choose chemoradiation over radiation alone, even if you told them that the survivorship is the same. And the reason for that was they wanted peace of mind. And I think this is a very, very sobering observation and a sobering report in a situation where we've just run a 1,000 patient study where we may be telling patients, this is 6% worse, but think how much less toxic it is. Patients may well say, whoa, whoa, whoa. You know, I'm not sure that a 6% decline in survivorship is equivalent. So we power for non-inferiority on statistical grounds, but the patients may not accept this as evidence of non-inferiority. Patients are going to define that themselves. And I've had the experience of talking to a patient for the HN002 and telling that patient that we had good reason to believe that the survivorship would be equivalent and the toxicity less. And the guy said, boy, this sounds good to me. And his wife said, what do you mean you don't know? The guy with the disease wants lower toxicity. His wife doesn't want to be a widow. And I think we should remember what we don't know when we're encouraging patients to have deintensification. And as a surgeon, I find these data somewhat disconcerting. Patients with T1 to 3 and N0 to N2C have a low risk of distant metastases as their failure mechanism. And we do quite well for tumor control for patients with even high-risk disease of T4 and N3, but they have a far, far higher risk of distant metastases than patients with less threatening disease in terms of prognosis. Patients are dying of distant disease in this situation. And patients with N2B and N2C disease experience recurrence more often when they're treated with radiation alone. So what this means is we have patients who are dying of distant disease, and we should be very, very circumspect about pulling the chemotherapy out of their regimens. Now, we don't always think of our concurrent chemotherapy as affording distant control, though there are certainly suggestions of that in other trials. But we should consider carefully what it means to pull chemotherapy out of regimens when distant disease is an important failure mechanism. In the main, head and neck oncologists have embraced clinical trials because they provide promising insights and confer validity to our clinical observations and indeed alter practice, but they require ongoing scrutiny. And I think this is particularly important because we sometimes make mistakes in design. Now, this is the late report of 10-year follow-up of the RTOG 9111 study comparing methods of non-surgical management for larynx cancer. And what we see is at 10 years, the larynx preservation rate of these patients with advanced larynx cancer is preserved. This is a gratifying result. But the study endpoint was not laryngeal preservation. The study endpoint was laryngectomy-free survival. Now, laryngectomy-free survival is a composite endpoint, and I have learned as a trial designer to hate composite endpoints because what they really do is equate two different outcomes as the same. Is losing your larynx the same as being dead? I submit it's not. And you might as well say alopecia-free survival as an endpoint. Now, we'd all recognize that as an absurdity. Nonetheless, losing your larynx is not the same as dying. And when we designed this study, and it was designed by great head and neck oncologists, I think using a composite endpoint was a mistake. When you look at the long-term survival data, what you see is that they are all about the same. Now, one of the untoward consequences of this was that it allowed proponents of an inferior laryngeal preservation regimen to say, look, this inferior laryngeal preservation gives the same death rate as larynx preservation. These are equivalent. I submit that they're not, because even if the death rates are the same in one arm, you've got a lot more larynges saved. But what we see on the right is the red arrow pointing to late non-cancer deaths in patients who receive concurrent cisplatin with radiation. These are non-cancer deaths. We don't know why they took place. They aren't referable to treatment toxicity as near as we can tell, and they're still happening 10 years out. Now, I ask myself, if I know how to counsel a patient about a better chance of saving their larynx with a late death rate, which is non-trivial and progressive, a decade after we treat their tumor and preserve the larynx. And it may well be that with modern treatment techniques, this unusual or unknown cause of death will disappear, but right now I think we should bear it in mind. And it's of particular moment if you talk to patients and non-patients about what matters most to them. In the column on the left, we see patients, and in the column on the right, non-patients. Patients rate being cured of their cancer as a far more important goal than people who are not head and neck cancer patients. Health professionals asked about it. This is a highly significant difference. And if you look down at the bottom, what you'll see is that non-patients think it's very, very important to have no pain, whereas patients who are surviving their head and neck cancer do not view being free of pain nearly as important as those of us who are not living beyond cancer. So we really need to bear this in mind when we treat patients. What do patients want? Patients want to be cured, okay? And we who are non-patients may think that things are important that patients do not recognize as important once they have a life-threatening malignancy. These are data surrounding survival outcomes in advanced laryngeal cancer. And what they demonstrate in a national database is that patients managed for advanced laryngeal cancer with non-surgical approaches have a worse long-term survivorship than patients who are approached with non-surgical management and so-called, and this is legitimate, larynx preservation. Now, I think we're getting better at it. The curves are closer together with shorter follow-up, and I don't think this reflects so much durable force of mortality, though that's possible, but also the fact that we may be better picking the patients who are candidates for non-surgical management and larynx preservation as opposed to those who need operations. And this is not an isolated finding. If you look at the National Cancer Database for patients who had total laryngectomy versus larynx preservation for T4A larynx cancer, you see the same thing. You say, whoa, why is this such a big difference? These are T4A larynx cancers. Weren't there T4s in the 9111? Weren't there T4s in the VA cooperative study? You know, if you go back and look at the VA cooperative study, years and years old, when we compared survivorship of surgical management with total laryngectomy to induction chemotherapy followed by radiation, those T4s in that study are T3s today. That's AJCC 5th edition. And if you just say, okay, it had T4s in it, what you're going to do is take patients with quite advanced disease who were never candidates in the VA cooperative study, manage them non-surgically, and get bad results. Now, I'm a surgeon, okay, and I'm not indicting the radiotherapeutic community. There's no doubt that these patients were managed not over the objection of a surgeon, but with acceptance of head and neck surgeons in this situation. But 2/3 of the patients, the T4A larynx cancer in this country, are being managed with radiotherapeutic techniques rather than operations, and our national results are just not so good. And remember what patients think is important. Lowest matters most on this slide. If you look at patients pre-treatment, 1 month post, and 6 months post-treatment, what you say is that cure is very, very important. Longest life, very, very important when they finish treatment. And you know, if you look at natural voice, intelligibility, and swallowing, patients don't believe that these are anywhere near as important as being cured or living longer once the treatment's over. So it's incumbent upon us as head and neck oncologists to remember this. And I strongly suspect that you would recapitulate this data in other environments where you employ an organ preservation technique. I do head and neck, not head and tail, so I can't tell you about bladder. I can't tell you about anal. I can't tell you about other non-surgical approaches, but I think we really should be careful that those of us who do not have the disease don't overrate something we think is important that patients do not. So we have issues to resolve for cancers associated with HPV. We don't know the significance of P16 positivity and HPV status for non-oropharynx sites, or how to treat how to stage HPV-associated oropharynx cancer, though those answers I think are really in, and we'll see the page proofs presently. We don't know how to ameliorate toxicity without compromising a pretty good, though not great, cure rate. Now, these are easy problems to approach, I think, but they're harder problems to resolve. And if you look at the true scope of the problem, what you'll see is that I've spent a tremendous amount of time in this talk discussing what's about 18 to 20% of patients with head and neck cancer in this country, the majority of whom do not smoke. And we have not devoted near as much discussion and, frankly, near as much intellectual effort to the overwhelming majority of patients who have tumors that are not caused by HPV. Now, what characterizes patients with HPV-initiated tumors of the oropharynx? They look like us, okay? We don't smoke, we don't drink, and we have all our teeth. I don't think that's the only reason that we study these patients intensively. We get good results, and we want more good results. We get the candy. This makes us happy. We think we're getting something done. But remember, for most of the patients with other head and neck cancers, we haven't moved results very much. These are results of the RTOGO 522 by P16 status. And in the yellow on the top, we can see that patients with advanced tumors that are caused by P16 do pretty well. Now, this isn't testicular cancer. We're not curing all of them. But we haven't moved the needle much at all for patients whose tumors are caused by substance abuse. And to me, that's disconcerting. So we have disappointing survivorship for those patients that whose cancers are caused by substance abuse, and even for patients with HPV-associated cancers arising in a background of tobacco use. And what we need to figure out is how to improve their cure rate without unacceptable toxicity. Perhaps this will come through identification of markers or the developments of new agents. So these are really interesting times in the treatment of HPV-associated cancers, but they're a distinct minority of head and neck cancers in the USA and throughout the world, and they're consuming considerable intellectual resources and capital. And there are too many opportunities in the treatment of cancers caused by substance abuse. And remember that carefully as we work and meticulously as we design, the results of trials should be interpreted with care. I'd like to thank you for your attention.